This video is going to review how testosterone changes bodies when people take it for gender affirming care. Testosterone is a hormone made by our bodies. Bodies with testicles usually make more of it than bodies without testicles, but almost all bodies make it. It can also be made in a lab. The testosterone we prescribe at CareerDoc is made in a lab, but has the same chemical structure as the testosterone made by bodies. We often call this testosterone bioidentical. Testosterone does many things in the body, and if you start taking it, your body will probably change. These changes may be something you want, which we would call a benefit, or something you don't want, which we might call a side effect or risk. Your set of benefits and risk is unique to you and depends on what you want for your body. We will try to give a general timeline in this video for when those changes will occur, but we can't predict it exactly. Timing of when changes starts varies by individual and dose taken. Most changes happen gradually, so if you notice something you don't like or don't want, you have time to talk with your clinician and decide if you want to slow down or stop taking testosterone. These changes can be permanent, semi-permanent, or transitory, meaning they go away if you stop testosterone. We'll include information on whether or not changes are reversible when we discuss each type of change. Testosterone can cause these changes in your body: thinning or loss of your head hair. Hair loss is often genetic, which means that the tendency to lose hair is passed down through families. The genes which affect testosterone-related hair loss are present in eggs, but not in sperm. If baldness is common among your relatives on your birthing parents' side, you're more likely to lose hair when taking testosterone. There are some interventions that can slow down or limit hair loss, so let your clinician know if you want to talk about these. Head hair loss is gradual, but you do usually notice it within the first year of taking testosterone. Hair loss can be a semi-permanent or permanent change. Once the hair falls out, the hair follicle it grew in has about a year before it loses the ability to grow a new hair. If you stop testosterone before that hair follicle stops being able to support new hair, you might be able to regrow that lost hair. After that time, about 12 months, after the hair falls out, your hair loss would remain even if you stop testosterone. It would be a permanent change. Additionally, most people will lose some hair along the hairline when starting testosterone because it tends to affect hairline shape. Growth of facial hair. This is also a biological family or genetic trait. If no one in your family grows a full beard, it's unlikely that you will. Facial and body hair usually start to change in response to testosterone in the first 6 months, but can take up to 10 years to fully develop. If you want facial hair without the other effects of testosterone, you could consider applying a topical medication like lantanopros to the places you want hair. You could also use makeup or prosthetic hair. Facial hair that grows while you take testosterone remains if you stop testosterone. Because facial hair stays, some people choose to take testosterone until they have the amount of hair they desire and then stop testosterone. If you don't want facial hair but do want other effects of testosterone, there are procedures like laser and electrolysis which can remove existing hairs and prevent new hairs from growing. Because hair can be managed this way, we consider facial hair growth to be a semi-permanent change. Deeper voice. Testosterone thickens your vocal cords, and this makes the pitch of your voice deeper. There's some very limited evidence that suggests starting with a lower dose of testosterone and titrating your dose up slowly may help achieve more change and a lower voice overall. Vocal changes actually seem to start with your very first dose of testosterone, but most folks won't notice them for 3 to 6 months. People who are vocally trained might start to notice vocal instability and changes in their range very quickly. The voice will reach its final destination after about 2 years of testosterone therapy. Testosterone does not affect vocal weight, resonance, vocal tilt, or vocal dynamics. These are all ways society interprets gender when hearing a voice. Some folks choose to take testosterone until their voice sounds the way they want and then stop. You can also try vocal transition with online courses, coaches, or speech language pathologists, or pursue vocal fold surgery to lower your voice. Voice deepness persists even if you stop testosterone in the future. If this is unwanted, you could use vocal coaches or surgeries to access a higher pitch. However, your voice wouldn't be the same as it was prior to taking testosterone, so we consider this change to be semi-permanent to permanent. Oilier, thicker skin, and maybe some acne. Skin responds to testosterone by getting thicker, oilier, and less soft to the touch. Testosterone stimulates increased sebum secretion from sebaceous glands, making oil from oil glands and clogged pores from skin changes, often leading to some acne, especially in the first 2 years of testosterone therapy. There are treatments available for acne, so please let your provider know if you're worried about acne. Also, thicker and hairier skin sometimes means it's less sensitive to touch. Change in your body odor. Your body odor will change in smell, and your personal smell may become stronger or more noticeable. Sweat and your body temperature. Testosterone can increase your basal body temperature. You might find that you feel cold less easily or hot more easily. You may notice that you sweat more often or just more. More body hair. Testosterone will increase the darkness, thickness, and fullness of body hair. These changes in your body hair will persist even if you stop taking testosterone, but you will not continue to get new body hair if you stop testosterone. Like facial hair, this is considered a semi-permanent or permanent change, as you would have to pursue hair removal procedures to reduce body hair. Fat redistribution. The layer of fat under your skin will probably get thinner. This gives you a more angular and veiny appearance. You'll also tend to store less fat around your hips, butt, and thigh region, and more in your midsection, giving you a more linear or square silhouette. This usually takes years to fully develop. The combination of skin, hair, and fat changes may also change how you experience physical touch and pressure. You may be less sensitive to skin contact. Bigger, stronger muscles. Testosterone will increase the strength of your muscles to a small degree even without exercise. These effects can be amplified by exercise or worked towards with exercise alone. Building muscle too fast can increase a risk of a tendon tear, and this can be harder to heal. It's important to build muscle slowly over time to give your tendons time to strengthen as well. Less chest breast fullness. Previously developed breast tissue will not go away when you take testosterone, but it will become less full, fluffy, or pillowy. This may make it easier to bind. Weight changes. You may gain some weight, usually about 3 to 4% of your body weight. This is probably related to your muscles getting bigger. Also, testosterone does tend to increase appetite in some people. Bottom growth. The generally most sensitive part of your genitals, your clit or phallus, gets larger, and this change persists even if you discontinue testosterone. You may experience some uncomfortable sensitivity or growing pains. These changes start in the first few months and take a year to develop. The sensitivity or growing pain stops once the full growth potential is achieved. However, morning wood, engorgement, and more intense sensation in the mornings is not uncommon for the duration of testosterone therapy. The changes in the clit or phallus can change the way you experience sexual stimulation or pleasure. Front hole or vaginal dryness and atrophy. Testosterone changes the tissues of the genital and reproductive tract. You may notice some discomfort with receptive sexual or masturbatory practices. This discomfort or irritation may happen even without receptive practices. Sometimes it can feel like painful urinary symptoms, dryness, roughness, or burning. You might even be more susceptible to urinary tract infection. In fact, we actually think starting treatment for front hole wellness should be done within the first 6 months of testosterone therapy for most folks. This treatment is typically estrogen. It's placed in the front hole and doesn't necessarily change the overall effects of what you'll experience from testosterone. Talk with your clinician if you experience any of these symptoms, as there are interventions and treatments that can help. Sex stuff. Testosterone often makes people think about sex more often or more intensely. It might make you want to have sex or orgasms more often. It might change what you find sexually interesting or appealing, what gets you off. It often makes people more visually stimulated than previously. Cervical changes. The cells of your cervix change, and this can make it more challenging to collect an adequate sample for cervical cancer screening, what's previously known as a pap smear. We often recommend front hole or vaginal estrogen prior to attempting cervical cancer screening to improve the likelihood of a successful sample collection. Decreased fertility. Fertility changes depend on how long you're on testosterone and your age. While you're less fertile when you're on testosterone, you're not completely infertile, even if your periods have stopped. In fact, some people have gotten pregnant while taking testosterone therapy. Talk to your clinician about birth control if you're likely to get sperm anywhere near your genitals, and if you think you may want to get pregnant in the future. We have pretty good data showing people who are reproductively mature 2 years past the start of their periods, when they start testosterone therapy, are able to access fertility even after 5 to 10 years of testosterone therapy. Fertility access after more than 10 years of testosterone therapy has less data behind it and is probably less likely. Reproductive tract cancers. You don't have an increased risk of cancer. You don't need a hysterectomy if you don't want one. The exception is trans and gender diverse people with cervixes have an increased risk of cervical cancer. This is not related to testosterone therapy. It's related to the fact that we screen less frequently and less consistently than our cis peers. Testosterone does not increase your risk of ovarian or endometrial cancer. Stopping periods. If you currently get a period, testosterone may stop your periods, depending on your dosing. Contraception and some other medications can also be used to stop periods in addition to testosterone or on their own. This usually takes 6 to 12 months, depending on dosing. Emotional stuff. Mood and emotional changes are often the first changes noticed and can be seen within a few weeks of starting testosterone. People often report feeling an improved mood, feeling happier, calmer, better. People often describe their emotional experience on testosterone as more simple and less complex. They say their emotions may be less intense and more stable. Some report that they feel more secondary emotions than they did previously. Secondary emotions are internal reactions to the primary or first emotional reaction felt, such as feeling angry after an event that first provoked fear. Some people find they are less easily tearful. People also find they are a little more irritable, but not angrier. If you feel intense increases in anger or rage, potentially your testosterone dose was started too high and escalated too rapidly. Speak to your clinician. Physical safety and discrimination. Being queer and trans, especially when you are more visibly so, increases your risk of minority stress, discrimination, and physical violence. These risks are amplified by intersectional identities. All of the changes we discussed where we didn't mention permanence or semi-permanence are changes that would revert or go back to how they were before you took testosterone if you ever stopped testosterone therapy in the future. There are some known possible risks with testosterone therapy. Cardiovascular disease, commonly known as heart disease, is a group of conditions that lower the heart's ability to pump blood, or the body's ability to get enough oxygen-rich blood to all of its parts. Cardiovascular disease does occur at higher rates among trans people, but we believe that's related to minority stress. Minority stress is the additional impact to daily life caused by prejudice and bigotry. We don't have a lot of research about changes in heart disease risk for trans people taking testosterone, but we don't think that taking testosterone significantly increases your overall risk of cardiovascular disease. And we do have information to indicate that trans people taking T who have heart disease are not sicker overall compared to their cis peers. This is all made more complicated because testosterone may cause changes in other body processes that are commonly used to estimate heart disease risk. And heart disease risk often build on each other. You can learn more about cardiovascular disease risk in one of our other upcoming videos. Testosterone causes increased red blood cell production. Smoking cigarettes, sleep apnea, living at high altitudes, and other conditions like uncontrolled asthma can cause your bone marrow to produce more red blood cells. Having more red blood cells may make your blood thicker, which can impact how smoothly your blood flows and how it clots. We recommend lab monitoring to keep an eye on this. Systolic blood pressure rises on testosterone. Systolic blood pressure is the first number in the blood pressure reading, or the top number. This is the measure of the pressure inside your arteries when the heart beats. So it's a description of how hard blood pushes against your artery walls. In the studies that looked at blood pressure changes on testosterone therapy in trans and gender diverse people, the change in systolic blood pressure did not have an association with clinical relevance, meaning we don't think it affects health outcomes currently. However, if you have blood pressure problems or problems with your kidneys, you should definitely talk to your clinician about potential risk and monitoring recommended if you choose to start testosterone therapy. Taking testosterone might raise your risk of liver disease if you already have other risk factors for liver disease. And if you have liver disease, testosterone might make it worse. The overall rate of liver injury after 12 months of testosterone therapy in a 10-year study of over 1,000 trans people taking testosterone was 0.4%, which is very low. Liver disease risk factors include exposure to toxins, including alcohol, some diseases such as hepatitis and other infections, and physical damage to the liver. Change in cholesterol. There are several different types of cholesterol, which are fats that are necessary for your body to do things like create new tissues for healing and growth. To be in your best health possible, you want higher levels of high-density cholesterol and lower levels of low-density cholesterol. Testosterone does not appear to change levels of low-density cholesterol, but might slightly lower the levels of high-density cholesterol. Triglycerides are another fat used by the body. Like low-density cholesterol, better heart health is associated with lower levels of triglycerides. Testosterone may increase triglyceride levels. Lower levels of high-density cholesterol and higher levels of triglyceride may put you at increased risk of developing cardiovascular disease as you age. Heart attacks. Trans people taking testosterone have a higher risk of myocardial infarction or heart attack compared to cisgender women, but there's no difference compared to cisgender men and no difference in outcomes. A heart attack is when blood flow to heart muscles is limited or stopped. This causes damage to the muscle and makes it much harder for the heart to do its job of pumping blood. Heart attacks are often caused by blocked blood vessels. Strokes. A stroke is when the blood supply to the brain is limited or stopped, or a blood vessel inside the brain bursts. There is no difference in how often strokes happen between trans people taking testosterone and cisgender men or women. Testosterone might impact factors that could increase the likelihood of blocked blood vessels and thus the risk of a vessel bursting or blood flowing to the brain stopping, but there's no clear link. Diabetes. Diabetes is the body needing more insulin to be able to manage sugars, also called glucose in the blood. Taking testosterone does not seem to have any impact on how the body uses glucose or the levels of insulin present in the body. However, testosterone therapy may lower the levels of a chemical that regulates insulin use. And lower levels of this chemical is associated with the body not using insulin as effectively, which could lead to diabetes. Having diabetes can increase the risk of blood vessel damage, which, as we've discussed, raises your risk of cardiovascular disease. If you already have diabetes, particularly insulin-dependent diabetes, testosterone therapy can change the insulin needs for your body. And so you should work with your primary care provider or endocrinologist to monitor your blood glucose and insulin needs more closely whenever you're starting testosterone or changing your dose. Blood clots in other parts of the body besides the brain. Thromboembolism is when a blood clot forms somewhere in the body and then travels to another part, often the legs or lungs, and gets stuck in the new location. Increase in these types of blood clots have not been seen in gender diverse people who did not have other conditions that would raise the risk of blood clots who were taking testosterone. A 2021 meta-analysis confirmed that there was no link between testosterone therapy and thromboembolism risk. If doing microdosing or low dosing, as it's commonly called within the community, the lining of the uterus, the endometrium, may get thicker. This is called endometrial hyperplasia. Hyperplasia can lead to abnormal cells and a higher risk of endometrial cancer because bodies on lower doses of testosterone are more likely to continue making estrogen, and the endometrial growth is dependent on estrogen. We typically recommend progesterone for endometrial stability if you want to take lower doses of testosterone in order to reduce the risk of hyperplasia. We do encourage regular blood pressure monitoring every 3 months in your first 1 to 2 years of therapy, and regular blood work to keep an eye on some of these risks. Baseline blood work for lab tests may be recommended. Our recommendations will be based on your pre-existing health and your personal values. Some people may choose to decline baseline lab tests, but will need to talk to their clinician about what the risks are involved in not doing baseline lab work. Testosterone can be taken in many different ways: pills, nasal gel, gel that is spread on the skin, and injections. Patches are no longer available in the United States. Gels and injections are the most commonly used form of testosterone in gender-affirming care. Pills haven't been widely adopted because they were just FDA approved in 2019 and currently don't have a generic form available, making them quite a bit more expensive. Also, they can't be cut or crushed, so the dose is less titratable or individualizable. Gel and injections both tend to be more affordable, and the doses are easier to change to meet individual goals. The gel is usually applied every day, usually to the upper arms. It can cause more hair to grow where it is applied. After applying, you need to wash your hands and cover the area with clothes. It is recommended you shower prior to skin on skin or skin on animal contact due to the risk of testosterone exposure to others. It's also suggested you wash your laundry in separate loads from the rest of the household. You don't have to use separate machines, just separate loads. Injections are most often done once a week. We usually recommend a subcutaneous injection, which uses a smaller needle rather than intramuscular injections. You can learn more about injections on our self-injection page. Thanks for learning all about testosterone with us. We look forward to helping you with all of your gender care needs.